Hello everyone, I'm Dr. Dipti, Kariya. I'm the PhD Physiology and your educator for Physiology. Today we'll discuss about coronary artery disease. Before starting my class, I would like to discuss you that you can get all my lecture notes in soft copy and hard copy. To get the soft copy, you download the application Vesalius and you have to subscribe. And to get hard copy, you can order my book, that is Physiology Notes, available on Flipkart and Amazon. Link for my notes, link for the application, they all are given in the description box. You also can join us on WhatsApp group. My number, that is 7863822668. Okay, so you can join us also. Now let us start with our today's topic, that is coronary artery disease, and that is due to insufficiency of coronary blood flow, and it is also known as ischemic heart disease, and it is one of the common cause of the death in developed countries. Now, what are the causes of coronary artery disease? They are atherosclerosis of coronary arteries, formation of thrombus, embolus formation, and spasm of coronary vessels. Now, starting with one of the cause, that is atheroma. What is atheroma formation? That is a patchy change in the tunica intima of large and medium sized blood vessels, and this atheroma consists of, you can see here, it consists of cholesterol. This is cholesterol, you can see here, this number 8, this is cholesterol, yellow color. Okay, smooth muscle cells, you can see here number 6, smooth muscle cells. These are fat filled monocytes, they are also known as foam cells, this one. Okay, then also it is covered with a cap that is made up of fibrous tissue, that is fibrous cap. Okay, so that is atheroma. And what are the complications of atheroma? This atheroma get rupture if it it may form intravascular clot, that is thrombus formation, and it may produce vasospasm too. Now, what are the causes of atheroma? Common causes are, it may be hereditary, family history of atheroma. Obesity is one of the commonest cause for the atheroma. Along with family history, environmental factors like obesity also play an important role. Then age, with increase in the age, chances increases. Gender, in females before menopause, there are less chances of atheroma formation because estrogen has protective effect. Diet, increase in the fat consumption, that also increases atheroma formation. Smoking also increases the risk of atheroma formation. Diabetes mellitus also increases the risk of atheroma formation. Sedentary lifestyle, as fat consumption is increased and fat utilization is reduced, so that is increase in the atheroma formation. Hyperlipidemia, increased lipid content of the blood also increases, and alcohol consumption, that also affects with the fat metabolism. So these are the common causes for atheroma formation. Now, what are the effects of atheroma? That is narrowing of the vessel because of the atheroma, clot formation, partial obstruction that results in ischemia or angina pectoris, and complete obstruction that results in myocardial infarction. Now, what is angina pectoris? This angina pectoris, it refers to chest pain due to ischemia of cardiac muscle, and this is the pain which is felt in the chest below the sternum on the right side of the, below the sternum on the left side of the chest, and it radiates to left arm and left shoulder. Okay, and what are the causes of atheroma? That is, what are the causes of angina? That is due to decreased blood supply that results in accumulation of P factor in the ischemic tissue. P factor gets accumulated. Okay, now next is myocardial infarction. If the ischemia is prolonged, ischemic necrosis of the particular part of the myocardium, you can see here, when the prolonged ischemia and the complete obstruction that results in death of the cell, that is ischemic necrosis of particular part of the myocardium. Okay, and this infarction occur due to more than 75% of obstruction of the coronary artery, and here ECG finding is an important tool for the diagnosis as well as localizing the myocardial infarction. Okay, precipitating factors for myocardial infarction, they are spasm of coronary artery at the site of atheroma. Because atheroma is there, it is partial occlusion, but if there is spasm, then the occlusion gets completed. Platelet gets aggregated and stress results in sympathetic stimulation. That also causes spasm. Now, in case of acute myocardial infarction, the person is having, how can we diagnose? Person is having severe chest pain. The chest pain along with excessive sweating, and pain may or may not radiate to the ulnar border of the arm. Most of the time it gets radiated, okay, ulnar border of the left arm, and patient gets relieved by sublingual nitrate, okay. And uh, in acute myocardial infarction, there is increased circulating level of lipoprotein, ultrasensitive C-reactive protein, oxidized LDL, antiphospholipid antibodies, troponin I, and homocysteine. Now, what are the ECG changes here in myocardial infarction? In case of acute infarction, there is ST segment elevation. You can see this is normal, this is ST elevation. You can find ST elevation in the ECG leads recorded with the electrodes placed over the infarcted area, and ST segment depression that is found when the electrodes are placed on the opposite side of the infarction. Okay, so you can see here. Another thing here, in all case of infarction, what happens? One, that is ST segment returns to normal sometimes. Okay, you can see here, but there is appearance of Q wave here. You can see, and T wave gets inverted. This one. This is in old infarct. Okay, increase size of Q wave and inversion of T wave. Okay. Now, what is the physiological basis of this ECG changes? Why there is ST elevation, T inversion? Okay, in resting condition, you can say that this is normal myocardium, normal cardiac muscle that is in polarized state, but the infarcted area that is in polarized state also, it has, you can see normal myocardium has negativity inside, but infarcted myocardium has positivity inside. So, or you can say there is decrease in the negativity. Okay, and alteration in the ECG changes in acute myocardial infarction, they are ST elevation, okay, in the leads of the affected areas. Okay, and what are the causes for this ECG changes? One, that is decrease in the resting membrane potential, it is less negative. Second, that is delayed depolarization of the infarcted area. Infarcted area depolarization is delayed and repolarization is rapid. Okay. So here are the causes. One, that is decrease in the resting membrane potential in the infarcted area here. Okay. Then depolarization of the infarcted area is delayed. Okay. And repolarization is rapid. Okay. That is responsible for this STT changes. Okay. Now, physiological basis of ECG changes in old infarction, few days or few weeks after infarction. The dead myocardium and scar tissues, they become electrically silent, and affected area becomes negative relative to the unaffected area. Okay, that is negative always during systole and fails to contribute to its share of positivity of electrocardiographic complexes. Okay, and this is manifested by, you can see here, Q wave is present, that is, okay, Q wave is present in some of the lead which was not present previously, or if sometimes if it is Q wave is present, that becomes T. Okay, now localization of area of myocardial infarction. If the person is having anterior wall myocardial infarction, okay, you can see in anterior wall myocardial infarction, lead L1, okay, limb lead 1, AVL, then lead number V, just a minute, sorry, lead number L1, AVL, L, lead number VL to V3, V3 to V5, they show changes of MI, okay, that is ST elevation, okay, and lead number L2, L3 and AVF shows reciprocal changes, okay. So again I repeat, what are the reciprocal changes and normal changes? Means in the area of infarction there is ST elevation. In this leads you have ST elevation. Okay, and here in reciprocal leads they have ST depression. Fine. Then now we'll discuss about inferior or posterior wall myocardial infarction. Here what happens? Suppose this is your inferior wall. myocardial infarction. So all the things are opposite. You can see here ST elevation that is found in lead L2, L3 and AVF. Okay, but ST depression or you can say reciprocal changes they are found in lead L1, AVL, AVR and just a minute AVR and V1 to V6. Okay, then in case of lateral wall MI, here in lateral wall MI you have ST elevation found in lead L1, AVL and V6 and ST depression that is found in lead L2, L3, AVF and V1. Okay, and in case of septal myocardial infarction, lead V1 to V3 they show changes of MI V1 to V3. Okay, so these are the leads in which you can find changes during myocardial infarction. Now other investigations to diagnose myocardial infarction, they are: number one is enzyme level in the plasma. Okay, enzyme released in the circulation by damaged and damaged myocardium. Okay, most commonly measured enzymes they are CK, creatine kinase, LDH, lactate dehydrogenase, and more specific enzyme they are CKMB. Okay, creatine kinase MB and isoenzyme of CK and fraction 1 of LDH fraction 1. Okay, then coronary angiography, that is also the procedure in which medical imaging of the lumen of the blood vessel that is possible. Here the procedure is radio opaque contrast agent that is injected through the vessel, you can see here, into the through the vessel, and X-ray images are taken simultaneously and that is displayed on the image intensifier or film or motion images. Okay, and it is used to visualize the detail of the coronary arteries. Also we can get the idea about extent of obstruction, site of obstruction. Okay, and physiological basis of management, medical management, you can see one is vasodilators. They are given nitrates, isosorbate dinitrate, that causes coronary vasodilatation. You can see dilatation of the coronaries, nitrates. Okay, and they also cause arteriolar dilatation. When arterioles are dilated, you can see that there is decrease in the afterload. Okay, here after, this is venous written, this is afterload, arterioles are dilated. Also causes venodilatation, so it decreases preload on the heart. So preload and afterload both are reduced and therefore oxygen demand of the myocardium is reduced. Then beta blockers are administered. Okay, these are beta blockers, selective beta blockers are administered. They also decrease the oxygen demand. Calcium channel blockers, they are also given. They cause vasodilatation because of relaxation of smooth muscle. These are calcium channel blockers and they also decrease preload. Myocardial contractility is also reduced by various agents. Okay, then in emergency condition, a drug streptokinase or urokinase or tissue plasminogen activator is given. You can see here, this is tissue plasminogen activator, urokinase or streptokinase. Okay, and how does it act? It causes activation of plasminogen. Here this is not visible properly. Plasminogen is converted into, this is plasminogen that is converted into plasmin, and this plasmin also known as plasminogen is also known as profibrinolysin, and plasmin that is fibrinolysin, so it causes lysis of the fibrinolysin, so it causes fibrinolysis, so degradation of meshwork of the fibrin. Okay, so that can be injected intravenously in the early stages of myocardial infarction and it removes the obstruction and it prevents further progression of the infarction. Okay, surgical management is also sometimes required, like coronary angioplasty, that is also known as percutaneous transluminal coronary angioplasty, percutaneous transluminal coronary angioplasty. Here removal of the obstruction of coronary artery, that is the main basis of the treatment. Here one catheter that is containing balloon is inserted in the coronary artery and this balloon is inflated at the site of obstruction. Okay, and that is to dilate the constricted artery. That is very useful for immediate treatment of acute myocardial infarction and It is assisted with medical and surgical interventions. Other treatment, that is bypass, when the or that is known as CABG, coronary artery bypass graft. When this angioplasty cannot be able to treat your block, then this is the other way of treatment, aortocoronary artery bypass. In this intervention, blocked artery is bypassed by implanting a vessel. One end of the saphenous vein or internal mammary artery is grafted, you can see here, and other end is grafted to the, sorry, one end of saphenous vein or internal mammary artery is grafted to the aorta, and other end is grafted to the coronary artery beyond the occlusion. You can see here, suppose this is your occlusion, you can see here, this is the part of occlusion, so that is bypassed. So from directly aorta, this graft is placed here on this healthy coronary artery, so we can restore the blood flow beyond this block. So we are bypassing this block. So this is the other surgical management. So this is all about your coronary artery disease. Thank you so much. If you like to get my all notes in soft copy, you have to download my application Vesalius and you have to subscribe. And for getting hard copy of my notes, you have to order my book that is available on Flipkart and Amazon. Link for my book, link for the application, all are given in the description box. You can join us on the WhatsApp group also. The number is 78638222668. Okay. Thank you so much. If you like my video, you can like it, you can share with all your friends and subscribe my channel. Thank you.